Yeah, that's a great question. I mean, it's hard to say what the typical patient for AFib is. I mean, clearly, the as the population ages, we see more and more patients with AFib that are elderly. But we also have better screening, and kind of patients are more plugged in with these wearables and implantables, that AFib is getting picked up in patients that are younger as well. And so really on both ends of the spectrum, we're seeing more of the arrhythmia. And in terms of what that means for our practice related to it, while we emphasize the prevention aspects and the lifestyle aspects to avoid progression of the disease, we also have lived by the dictum that AFib begets AFib. So it's very clear that the more time that a patient spends in AFib, the remodeling that occurs, the structural and electrical changes that happen over time are make it that much more challenging to achieve rhythm control if a patient has been in AFib for an extended period of time. And so because of that, we do tend to intervene sooner in the process than I think historically the mode of practice used to be. So according to the current guidelines, it is reasonable to proceed with an AFib ablation before a patient even tries an antiarrhythmic. And what that is born out of is that antiarrhythmics are not necessarily the safest medications in the world. They're not particularly efficacious. And in the subset of patients in whom they are tolerated and they do work, it is an indefinite addition to their medical regimen. And so given the polypharmacy that exists, particularly in the older population, that is something that is nice to avoid. The one other thing that I think is worth adding with regards to AFib for a primary care population is that, when I was a medicine resident, we kind of lived by the Affirm trial, that there really is no difference in outcomes between rate control and rhythm control, and therefore it is reasonable to just do rhythm control for patients. Kind of being on the more interventional side of this, I've a few insights that I've gained are that what that trial looked at was really at minimally symptomatic patients. It were patients that were willing to be randomized and didn't mind being in AFib. And so while there's plenty of literature that suggests that even in those patients we should consider intervening, I think that from a primary care perspective, one of the most important things is trying to determine whether a patient is symptomatic or not. And so kind of like in CPR, you're not dead until you're warm and dead. In AFib, you're not asymptomatic until you're in sinus rhythm and you have demonstrated that you do not feel better than you did in AFib. So there's plenty of patients that show up in persistent atrial fibrillation and say, "Doc, I'm asymptomatic." Well, 9 out of 10 times when that patient is cardioverted and put into sinus rhythm, they don't realize that they've just kind of adjusted and gotten used to what it is like to live in AFib. And so I think every patient deserves that trial to try to see whether their quality of life would be substantially improved by being in sinus rhythm before they are kind of relegated to a rate control strategy. Because once patients go down that road, it is much harder to get them out of AFib and effectively maintain sinus rhythm.